So let me introduce our panelists here. We have Jacqueline Meany, right, from the VA. You want to tell us a little bit about yourself?
Yeah, so I'm a mental health clinical pharmacy specialist. So essentially that means I did my pharmacy degree, which is a doctorate degree. And then I did 2 years specializing in psychopharmacology. And then I got board certified in psychopharmacology and ambulatory care pharmacology. So I'm double board certified for both. So
Okay. Yeah, and you've been working at the VA.
Oh, I've been working at the VA for a long time. I've worked at 5 different VAs throughout Valley program, residency, and now I work at Valley Coast Fund for the last 2 years in Corpus.
Gotcha. So sorry to put you on the spot, but about how many patients do you think you see in 1 week? If you had to guess.
Like 10 per day.
10 per day, so maybe 50 patients a week? Something like that?
Probably slightly less than 50, but it's a good ballpark.
Okay,
It's
that's
just a lot of walking.
It's a lot of...
It's a lot because the thing is we have standing access that's mandatory. So if you show up to the VA with mental health problems, we have to see you that same day. So it varies so much. Or if someone is suicidal, then I won't be seeing the next 4 patients. I will be dealing with that one patient for the next 4 hours while we try to get them admitted. So
Excellent, thank you.
yeah.
All right, and so we have Nedia de Lua
Ruiz, yes.
There we go.
Hi, I am a psychiatric mental health nurse practitioner. I do a little bit of private practice with South Texas Mental Health Associates, where we see adult patients 18 and up. I treat a variety of different mental health illnesses, all the way from depression to schizophrenia, ADHD, generalized anxiety disorder, just to kind of name a few. I also see patients in the inpatient hospitalization side at Baby Behavioral Hospital. Again, I do 18 and up, as well as the geriatric department. And then in addition to that, I also treat adolescents in a kind of a forensic psychiatry type setting. And I do that through telemedicine at least 1 day a week for a couple of hours. And that's always nice, and it's a little bit of a change of pace in terms of population age needed. And then in addition to that, I'm also a full-time faculty member with the College of Nursing out at Texas A&M University, where I do teaching in the undergraduate nursing program.
She has found an extra 4 hours in the day that none of us have yet. Okay, so Mrs. Stephanie Meany.
I'm Stephanie. I am a counselor at the University Counseling Center. My colleague Anna is here with me today too. I'm an LPC, and I'm also an NCC. I'm a doctoral student in my 2nd semester of the program here on campus with my lovely cohort members up here. And so before the counseling center, I was the eye care case manager at the university. And then prior to that, I came from community mental health and worked for, at the time, it was Behavioral Health Center of Nueces County Youth Services. The students that I see at the counseling center, the majority of the reason they're coming in is for anxiety. So this is something that we see quite often.
Excellent, thank you so much. And
Hello, my name is Anna Salazar. Can everybody hear me back there?
Yes.
Okay. So I'm also an LPC. That's not the role that I currently have, though. I work at Texas A&M University Corpus Christi inside the Counseling Center as a clinical case manager. My experience, though, is in therapy and case management in the community. I worked for several years at Nueces County. Used to be MHMR, then with Behavioral Health Center. Nueces County MHID. Sorry. For many years as an adult case manager for level 1 care, upwards of 200, 250 clients at a time. And then I ran the Robstown Clinic for a couple of years, and there I supervised and trained case managers who treated clients all the way from 3 years old to, 80s geriatric ages. So right now in my role at the university as clinical case manager, I take care of students' basic needs, crisis intervention, hospital follow-up, continuity care type needs.
such a amazing lens though, right? Like to see somebody just in front of you, have all the areas of need that could be met. So thank you all for coming here and spending time with us. So today our conversation will be surrounding this case study that we put together about Stephanie, who's a 41-year-old admin assistant who was referred to mental health treatment by her primary care physician after she talked about always being on edge. She lived with her longtime boyfriend for a while, and he abruptly ended the relationship. And somewhere after that, she began to agonize about routine tasks, especially the possibility of making mistakes. Talked about always feeling tense and fatigued, difficulty focusing, worrying excessively about money, to the point where she decided to downsize apartments, move into a tiny apartment in a different area of town. Always seemed to be worrying about being a burden for folks. Her symptoms had gotten to the point where she avoided going out at night, thinking that something bad was going to happen and that she'd be unable to summon help. She avoided going out in the daytime too because she believed that she would feel exposed and vulnerable, to the point where she stopped going to the grocery store. Was like, how can I have food delivered to me? But in her apartment space, felt calm, relaxed, could do things like read a book, enjoy movies, stuff like that. Totally denied any sort of feelings of worthlessness, guilt, hopelessness, suicidality. Weight's not changing, no psychomotor agitation, but did score a 28 on the Beck Anxiety Inventory, which is in that severe range. So, panelists, you hear a case like this, what jumps out to you?
Her avoidance, that's the number one thing that I kind of noticed in terms of the counseling perspective, her avoiding going out, her having food delivered, this breakup caused, it seems like it is maybe have been the trigger for the anxiety, but her avoidance is more than likely making her anxiety worse. And so that would be something that I would want to take a look at from the counseling perspective, figure out what's going on with that.
So I think for me as a nurse practitioner, what kind of stands out for me is the changes that she made kind of overall in her lifestyle, downgrading her apartment, for all these different various reasons, and like she said, was the fact that, kind of trying to identify the trigger point, and it seemed as though it was, the ending of this particular relationship. But anytime a patient comes to me and they've made big changes to their routines, to their life, that tells me that there's a big impedance in whatever it is, whatever it is that we're looking at. So in her case, it's anxiety. So that tells me that I need to be maybe a little bit more aggressive in my treatment, just simply because we don't want it to continue to kind of move down that road. And so this is somebody that I would just kind of keep those things in mind. Also, of course, I would take into account her age as well. 41 years of age. I also think about as well, is there anything else that could be going on with this patient outside of just the anxiety? Given her age, are we looking maybe at somebody who might be going into early menopause? In other words, is there something medical that can also be playing into this as well? So again, that's just from the medical side, being a nurse practitioner, that I kind of try to look at the whole picture of things.
Yeah.
So.
Can you talk a little bit about some of these other medical, right? Because if we're looking at DSM-5 criteria, we have to rule out any sort of medical
Right.
Causality.
Yeah.
Anything stand out for y'all?
So I think the other thing that I look at is TSH also, like thyroid, any kind of thyroid function issues, because that, when you take a patient, like let's say for instance, who's hypothyroid, it looks like a depressed patient. You take somebody who's hyperthyroid, they look like an anxious patient. And so I think labs are also really important in kind of getting a baseline function, and of course history. That's a big piece of it for me.
Yep, that is exactly what I circled.
Oh, y'all have the same
So
notes.
give it a-
Excellent.
So for me, from a medication management standpoint, since she's showing signs of, very severe anxiety, but mixed in with a little bit of, depressive symptoms, nothing atypical or typical about her weight changes, it's fine, sleep is fine. I'd be approaching this with basic, standard SSRI, SNRI treatment. So sertraline, for sure, I don't know if you're familiar with brand names or generics, but your Zoloft, your Paxil, your Luvox, whatever you want to go for. Anything that's going to hit both depression and anxiety. She's presented with both persons who use for treat anxiety. Wouldn't go for mirtazapine because she's not having issues with sleep. But if she was having insomnia, which can be caused by a lot of antidepressants, I would go with mirtazapine. And oftentimes you do want to offer a sleep aid with an antidepressant because a lot of them do the side effect of insomnia. So that would definitely be something to think about. And then for her age, I would definitely want to be running thyroid tests.
So all of that, there was like a flurry of
I-
medication
I don't know
names.
if I went too
So,
far.
final answer, like for you, what do you think would be your conceptualization of maybe what she might be dealing with, and then like specifically how you would treat that?
Okay,
Yeah.
so she's dealing with, severe anxiety with agoraphobia, a little bit of depression, not a major depressive disorder. In my original case, she was having a panic attack as well, so I would put her on a medication that's FDA approved to treat panic attacks.
Okay.
Panic attack prevention, social anxiety disorder, generalized anxiety disorder, and depression. So I would be on sertraline, Zoloft, which is, our go-to.
Okay.
First medication, because it is less harsh on your kidneys, less harsh on your liver, and less harsh on your body overall, compared to the other ones.
So definitely you see this as maybe like a candidate for a Zoloft.
And antidepressants, yes.
Yeah, and yeah, that's exactly what it is.
So as far as the anxiety effects, it takes a while to kick in. It's not like the first dose of Zoloft you take it starts working, something like that. There's some studies that show that within a couple weeks, it can start to work for depression, but anxiety can take up to like 12 weeks for it to start to work. So you need to keep slowly increasing the dose over time. So.
And I think from the counseling perspective, because of that, I would also want to check in with Stephanie about any substance use or misuse that she may be using to self-medicate. I see a lot of students struggling with anxiety who do self-medicate with marijuana, with alcohol, particularly marijuana though. So I would really like to know more about any history of substance use or abuse, especially since she may be taking medication.
Yeah, that is a curious omission from this case, right? Because so many folks that deal with anxiety to this degree, I mean, when you're not going to the grocery store, like, it's really starting to like impede just like ability to start having like basic needs met, things like this. So that follow-up for any sort of substance or self-medicating would be really important too.
Yeah, so I would also, in addition to adding medication, I would be referring her to my counselor and on my team. Because the medications, I'd explained to her that they're gonna take a while to kick in, it's not gonna be immediate, so I'm referring to counseling to help you out while we get the medications going.
Well, and we know that part of the gold standard treatment for anxiety on its own is counseling. That is at the very top of the list. Medication is adjunct to therapy and the work that they're doing with their individual counselor and so forth. So.
What about you? When you look at this case, what do you kind of see?
Well, for a case management perspective, I need more information. There's an incomplete picture here. I don't think there's enough information about who are her supports. Is she actually going to work? What are her finances actually like that she's having to make these drastic changes? Has she made appropriate a review of them? I mean, she's 41 years old. How long were they together? Did they have shared finances? What was that spark that's, oh my God, now all of a sudden I don't have money. Now I have to move to this place I don't like.
Yeah.
And to just be aware of kind of the normality of what she's doing. It's okay to get your food delivered, but where does that interfere with your ability to overcome these anxieties? Are they negative coping skills? You're going to have to address that in therapy. How much is that interfering with any progress that you might make? For someone with depression, for example, it's a great tool to pre-order your medication, have it delivered since you can't leave the house, you're kind of worried, really depressed and can't get out of bed, but if you're super anxious and avoiding places, that's something you don't want to do. So how many other tools is she using to her, quote, benefit?
Yeah.
That's really interfering with any progress that she might have. And I'm really worried about her supports. At 41, there's only mention of a longtime boyfriend, and she has some coworkers and who? Coworker and mom. Are they here? Are they far away? Is there somebody else she could live with to share those finance costs if it is something that's that drastic? What else? I have a lot of questions. This is
Yeah, I mean.
for a case manager. This
Yeah.
is kind of
Pretty much for anyone like an intake, doing an intake, this is such a small picture. You need to know her past history. Has she been, abused before? Is there a reason that this is sparking such a strong reaction, right? Because there could have been some childhood trauma or something going on in the background. So there may be other disorders that we need to take a look at and rule out or rule in before really proceeding legally.
I also get concerned about being with a boyfriend for a long time. What does that look like being with a boyfriend for a long time at 41 years old looks different and might mean years versus a long time boyfriend with someone who's 18 or 19, and it might be like 6 to 9 months. You know, so what was that relationship like? Did they have any codependency needs, or did she have any enmeshment problems? Again, more of that history stuff that you could do in an intake of counseling, and to kind of figure out some of those barriers and or extra supports that she's gonna need.
So let's just speculate about this. Let's just say that, you know, mom is in town. They were together for a decade. Her and the boyfriend were together for a decade. Just decided never to, you know, tie the knot. And somewhere in their lifestyle, their social circle just became smaller and smaller. And to the point where she maybe doesn't have a whole lot of friends outside of work. And then her immediate family, which wouldn't be unheard of. So with that in mind, what do y'all think about the importance of that social network and what can be built around that social network and how to intervene, because that level of support is going to be crucial for overcoming this anxiety, but in itself could be anxiety provoking too, right? The challenge of making a friend or enriching a connection already could also be anxiety provoking too.
And making friends looks very different, again, at 40 years old than it does at 19 or 20 years old.
Oh, it comes so easy when you're young. Do you want to be my friend? Yes? Okay, we're friends. And there's versions of that that get more mature in college and post-college and things like this for folks who go. But yeah, at 40s, making a brand new friend, a buddy, it's different, right? So what do y'all see about the role of this?
I think a lot of times when I'm working with students, and I have worked with some 40, 50-year-old students who are experiencing this type of anxiety, they want that social support, they want those connections. It can be anxiety provoking at times, like you mentioned, Dr. Lenz, but I think for the most part, what I've done with students who want to have that kind of connection, like that's an ultimate goal. Like we work towards that, and we work towards incorporating more of those types of social supports in their life, and in what that would look like for them and how we get there. But it takes baby steps a lot of times. But for me, that would be kind of the ultimate goal, is to get them connected to more social supports.
You could build on what she already has. I mean, she reads books and watches movies, you know. So building on what she already has, and then small steps. You already know a coworker, inviting them over to watch a movie or have dinner. You know, kind of creating that home security, but not keeping it there, because that might be a negative coping skill for her. You know, and then how do you branch out from there? Can you go to a book club? Can you go to the bookstore at a book club where it's a bunch of people are strangers?
Mm-hmm.
So kind of those baby steps, and then encouraging it with therapy, make sure she's taking her medication, using the timing of when she does these events to the best effect on when she's taking her medication. Is she brighter in the morning, in the afternoon?
And meeting her where she's at.
Right.
Where is she comfortable? If she feels more comfortable spending time with mom or some of these coworkers, starting there and building.
Yeah, and I even think about the importance of engaging the few links that she does have, like mom, right, is being sort of that safe person that you can partner her with, and sort of start generalizing that safety out into a bigger, I guess, scope of leisure space. Which is something that I've been really thinking a lot about recently, is this idea of leisure space, right? I mean, we live in a town of, Corpus Christi is about 300,000 people. It's actually a pretty big, sprawling area, but we see people who develop anxiety disorders or other syndromes, and the amount of that town that they use, in her case, the size of her apartment at this point, and the size of her office. So her leisure space combined is, you know, what, like 1,000 square feet? Out of all this area, out of all the parks and the movies and the shops and the entertainment, all these other areas, it's become just this small little area. And I'm curious to y'all about the importance of being out in the community and sort of like reclaiming that experience of being in the town that you live in for treating anxiety disorders.
So, since I work with, I only work with veterans, but for my female veterans, we do have a women's group. So I refer them to a women's group, which can be anxious at first, but I let them know it's not a round table. You don't have to talk if you don't want to. So basically, a lot of my patients recommend going to church. Just start going to church, start interacting with people, start building relationships, have somewhere that you can go where you feel like you've got a center of support. And that's really helped a lot of people.
I think it's important that we need to get her back out into the community. We need to get her back out into the grocery store. We need to get her back out into doing the things that were part of her normal daily life at one time. And so I think, like you know, these ladies said, that's an ultimate goal. Obviously, we're not going to get there in 4 weeks, 6 weeks. It may take months, but this is kind of where medication management really comes into play, is kind of getting a good grip on those symptoms from a pharmacotherapy standpoint, in addition to counseling, and then eventually with a long-term goal of being able to get back to doing all these things that she once did prior to this episode. I think one of the things that's really missing from this as well is this her first episode of this happening? So again, there is still, like we said, a lot of missing cases, but past psychiatric history, family history is huge also. I want to know, has this happened to her mom before, or anybody else in her family? Because those are all things that we take into consideration as part of the treatment, and also to recovery, because that's ultimately our goal, is getting back to recovery. Recovery for her is getting back to her quote-unquote normal life prior to, you know, this particular episode occurring. And so, but yeah, I think that those are really big pieces to kind of look at.
That's actually a really important point. You mentioned looking at the family history. So even from a medication standpoint, if, let's say, you suffer from depression and so does your brother, the medication that works for your brother is likely to work for you. So that's where we start. You know, so we always go through, you know, do your parents have something? Does anyone in your family have any kind of disorder? What's worked for them? Do you know? So that's where we'll start. Because with any depressants, you can kind of choose whatever you want. But a good starting point is if you can find something that's worked for another family member. That's the best way to get the right one to start with.
So I'm wondering if we could talk a little bit about, we've sort of got, like, you know, it's all mental health, but we've got more of the medical side and then more of like the intervention on the daily living level side. What kind of information do y'all need from one another, or would you like from one another in a all consents have been filled out magic wand type of moment? What kind of information through because this is a long-term treatment. This isn't a brief intervention for somebody who's this severe. You're talking, let's just say, you know, 4 or 5 months of therapy plus medication management. What kind of information would y'all like from one another during that time?
I mean, so I assume they would want to know if my patients are being adherent to the medications. Are they taking their medications at all? Because there's a lot of side effects, there's a lot of barriers to adherence. So we always want to make sure we're addressing that. So, you know, the counselors that I work with do a great job of addressing that. Are you taking your medications? Are you not? If they're not, they let me know, and I pretty much see the patients a walk in to discuss, you know, what's going on. Is there a side effect? Can we fix it? Switch the medication, make it better. And then in our chart system, I can review their notes, so I can see how they are progressing through therapy. So that helps me a lot.
I think from the counseling perspective, the therapist, or you all as future counselors, are going to see your clients, in this case for Stephanie, hopefully weekly, and they would only be seeing their doctors or nurse practitioners for medication once a month, once every other month, and then when they're feeling better every few months. And so as counselors, we're going to have more interaction, and so it's important for us to have those consents in place and be kind of doing a little bit of diagnosis and medication education to check in terms of how they're doing with that medication, so that way we can communicate that to whoever their provider is. And so as counselors, that's something that's really important to keep in mind, is you're going to see this person weekly. And so it's helpful for you to communicate with the other providers and keep everybody kind of on the same page, so that way we're better serving our clients.
I think that is really, really important. I know for myself personally, I really appreciate when counselors whom I've refer some of my patients out to communicate with me on the interim, because she's right. I may only see that patient once a month or once every 2 months, and once they get stable, it may even be once every 3 months. And so Whereas I expect for my patient to continue seeing the counselor, however often they decide upon is beneficial to that relationship, which likely is going to be still more often than they come to see me. And so the things that I like to know from the counselors is my patient digressing? Are we going backwards? Is there something, are there new symptoms that are emerging that would warrant me bringing that patient in a little bit sooner? If, of course, if there's a crisis, I absolutely would love to know about that, and what were the interventions. Medication adherence, a lot of times what the patient says to me is going to be different than what they say to you all. A lot of times you guys are their safe place because they spend more time with you all in your offices. They're seeing you more often, and so they divulge more information oftentimes to the counselors than sometimes they do to us as clinicians, as providers. And so anything new that maybe you think that I need to be aware of, that's something that I absolutely want to know. And so, or if their symptoms are improving, I also want to know what the progression is as well. Are we getting better? You know, what do we need to keep working on? What do I need to kind of discuss when they come to see me that once every, 2 months or whatever the case may be? I also want to make sure that I give my patient praises when they come in for sticking to the plan and meeting with their counselors and doing good work. I always like to kind of integrate into that. I touch base, and I think it helps the patient feel comfortable and more safe knowing that they have a team behind them versus just one person here or one person there that are not connecting. So I'm kind of a big proponent in collaboration. I think it's important. In terms of when we're working with patients, if we can get that down, I think that that's a really good thing, and it's the patient who benefits overall at the very end. So,
And in a perfect world, we would have consents for everybody. Everybody would have, have access to be able to see the treatment plan, so to know, okay, what is everybody's role on this team.
And so that's what they have with the VA. That was what here as. So I can see. So we're split up into teams. I'm team 3. So on my team, I've got a psychiatrist, me, the pharmacist. I've got a psychologist, an LPC, an LMF, licensed marriage family counselor, therapist, a social worker, a nurse, and a clerk.
Everybody's there. Like everybody's
so
on that team, right?
I've everyone.
Yeah.
The psychiatrists are usually located over Telemental Health from Houston. We have very few that are actually located physically here. But so essentially we all collaborate. So we can see all each other's notes. If they come in for a nursing visit, as a walk-in, we can see what happened at the nursing visit. We can have our nurses do follow-up phone calls, like every 2 weeks after starting medication. Like, hey, are there any side effects? What are you doing on it? Checking with the patient. So,
And at the counseling center, we have some amazing counselors and psychologists, and we have our clinical case manager, and we have an amazing psychiatrist, Dr. Zink. But we sometimes have to refer students out. And so that's where having those consents in place and communication and everybody being on the same page, having a treatment plan, having a safety plan, if there's been a safety plan that's been implemented, so that we're all being consistent and giving the same message to the client.
And so let me ask you this: at the counseling center on campus, y'all are like literally next door to the health center. Is there a bridge of access for those health records too? Like, so how do you think things would be enhanced if you could see sort of that medical history on the front end instead of relying on that self-report?
And that might not be the best scenario for cases like this, because the health center also treats clients without mental health needs or concerns.
Yep.
And so for the ability to just pull up someone's chart and just say, oh, they were seeing them also for these kinds of things, there are some protected classes of health information that I'm not supposed to have access to. And then also on the counselor and case manager side, building the rapport and letting them self-report and creating that relationship to understand their history together instead of just pulling up, oh yeah, I see you have all these things. Getting consent and then being able to access those things would work, and it could be helpful.
And we work closely with the health center. We have a referral system where we can send them to the health center. I've had to do that for students who were sexually assaulted and needed to go over there for STD testing or pregnancy testing, or they're experiencing some sort of medical issue in addition to the anxiety. So getting them over to the health center is always a priority.
Thyroid problems or, pregnancy or whatever it is we're working on.
Right.
And that's where that consent.
Luckily we have primary care. There's a lot of turnover there as far as start the med management, but, we would then refer that to the specialty that would fully yield that. We can just get them started on something to relieve the symptoms.
But I think that's a good point you make, and the fact that here the VA system, they have a great system. Everybody's integrated. They all have access to each other's charts. They have the whole team. They have like what we dream of, right, in private practice. But that's not the case for like me, for instance. I cannot see anybody's charts. I can't see any of my counselor's notes that work with my patients because we are all in separate entities. We all use different documentation systems. We are not under one umbrella, so to speak, like with a health system. And so I think with that being said, I wish that I had more access to progress notes and psychotherapy notes of the therapists that are treating my patients. That's just not the case. And so I think with that being said, it's important to know whose patient are you seeing? Is this somebody who has access to my records and can I see theirs? And if not, I need to make more effort then to communicate and collaborate with that particular person on the other side to ensure that we're kind of all staying on the same page. And I think that's where the ball tends to get dropped sometimes, and I think as a whole, we can all do better from that aspect.
Yeah, and thank you. That's sort of the point that I'm trying to arrive to is even when we have all this information, it's still a cloudy picture. You know, and I think that the ability to not have to rely on a mental health counselor who's seeing 8 to 9 clients a day, a pharmacist who sees 10 clients a day, to find the extra bandwidth to communicate to us about tomorrow's appointments. That ability to, I mean, even I think about the utility of maybe someone doing medication management. A typical anxiety treatment protocol is going to involve every week they're filling out an anxiety symptom inventory, and in some cases it'll be plotted so we can see their time series of symptoms. So if I can see that there was 6 or 7 weeks of progress, but the last 2 weeks have been markedly spiked, that may work into the conceptualization of medical management. And vice versa, it might be a good place to start that conversation. And when records are fully integrated, Stephanie could just shoot an instant message over to the medical provider or same, and they could walk right over it. Right? So those truly integrated electronic medical records are just really amazing.
That's why I was with the VA for so long. That system, it helps you so much. You can see all their labs, imaging, literally anything they've ever gotten done is right there at your hands. EKGs, anything that needs to look at for medications.
So if you're not in a lovely system like the VA where you have that, that is actually where you would use your case managers the most. Okay. So I am a clinical case manager, but there are non-clinical case managers and or social workers that, as future counselors, that you would be working with. And it is usually a system where they have a case manager and a doctor, or maybe a case manager or a social worker and a psychiatrist, or maybe so there's pieces of the puzzle, and that's where you're really going to have good rapport with your case management team, because they're the ones who can do the field work. They're the ones we're the ones that can do the linking, making sure the consents are on file, making sure that the appointments are all keeping track of, that they're reviewing their charts thoroughly and making sure that if Nedia is prescribing them an antidepressant, that they're not getting one from their OB-GYN as well. And kind of sharing that information. A case manager will also hear very, very different things than a counselor or a psychiatrist.
Absolutely.
Because we're going to see them typically more often. We're going to see them out in the field, in their homes, in their office, sitting across the table from us, having a more business relationship than like across a couch being comfortable or in a medical
Or
office.
just like a different level of comfortability. Or like, so for example, if I see primarily male patients who may not be comfortable talking with me about certain side effects of certain medications, so I will often find that out through my counselor, who is male. So.
Yeah, that's a really good point you make about case managers. I think, having worked in a large mental health system, and you look at something like our county's mental health system, MHID, and it's like this place runs on case managers, they're by far the biggest piece of the workforce, and really keeping it going, in a lot of ways. Everybody has their role and makes their impacts, but you sort of look at it. So as we transition here, I'd like to open it up to our buddies over here and see if there's any questions or comments about treating anxiety or working as a team.
So I have a question. So let's say that you know that your client vice versa, see someone in counseling. Do you ever have a conversation with them about what they can say as far as their current progress or their symptoms? You know, I know case management, and we're at MHA, we sit in and we can have that dialogue with the doctor, but like for the counselors and for you guys, you know, had that conversation, so what does that look like?
Like, do we have a meeting together with just
No,
us?
like if you have a client that sees a counselor, after every time you tell them, hey, maybe you should talk to your counselor about this symptom or this progress, like.
Yeah, I know I do that quite often, when I'm seeing patients and I'm making referrals out. If we identify something in my, 25-minute session with them, I will ask them, is this something that you're working on in counseling? This particular thought process, this particular fear, and if not, I want you to, let's bring this up with your therapist when you go back and see them. I think that there's some work to be done here, and between both of us, I think that we can get maybe to where we want to be. And so I think it's identifying, what the needs are of the client, and what areas still need attention, and communicating that with the patient. I want you to go back and talk about this with your therapist. Or sometimes the patient will come back to me and tell me, my therapist said that I needed to mention this to you, and I appreciate that. And kind of with that being said, one little thing that I do want to kind of throw caution out to the therapist is just to be mindful when you start talking about medications with patients, because that does sometimes put us as providers in a difficult position. I have had patients come back to me and say, my therapist thinks that I need to be on Xanax for my anxiety, and I'm like, okay, and they're like, so how come you don't have me on Xanax, and I'm like, well, there's a whole host of reasons why we don't have you on Xanax. And so those are instances when I wish that the therapist would have maybe called me first and talked to me and said like, hey, I'm just having some thoughts about this patient, based off of their history. I'm kind of wondering, do you think maybe Xanax or benzodiazepine or something of that nature would be a better treatment option for this patient's anxiety? Because it's so high and it's so severe. Rather than bringing that to the patient and telling them, can you go talk to your psychiatrist or your psych NP or whomever it is about this? Because it makes it a little difficult, and I think it hurts the relationship between the patient and the provider, or vice versa, the patient and the therapist, because then it's like, well, one of you isn't giving me what the other one thinks you should, so who's right, and that kind of thing. And so that's kind of the one
So
thing
to
that
find yourself triangulated, right?
Yeah.
And
Yes.
another layer of difficulty for that experience can be that sometimes I think what people hear is not exactly what we've said.
right.
And so there may be a message that's received, but what is heard and received is, I should be on Xanax.
Yeah.
Yeah, so
Yeah.
I've had people come crying in my office saying, oh, my therapist told me that I should not be on my Klonopin, that I could stop it immediately. And I've been on it for years, and I'm so scared, and they never want to do therapy again.
Just negative head nods over
Yeah,
here
we're
from
just-
this
no.
group.
Yeah, so it's like, I know that my counselor did not say that,
Yeah.
but that's what my patient heard.
Yeah.
And I think that's an excellent question. As a therapist, I would never tell.
I know my
Because
therapist
I'm
never
not
said
the
that.
doctor, and I think that that's important to communicate to your client is,
Carefully.
yes, as the counselor, excuse me, we're not the doctors, right?
Like a
So-
benzo is not indicated in PTSD with exceptions. So, just making that blanket statement, oh, you're on a benzo, you have PTSD, that's not appropriate. Careful with those words, because they may have panic disorder, they may have something else, they may have severe PTSD when we do need to use it. So, I have had counselors kind of cross that line, and then I have a very hard time convincing a patient to go back to counseling, and they absolutely need it, because we need medications is Band-Aid. Counseling is what they really need.
So as a counselor, you're gonna want to teach your client how to self-monitor and how to advocate for themselves. And so sometimes that requires a little bit of coaching, that requires a few sessions sometimes, but teaching them the importance of self-monitoring and self-advocacy. Because eventually you're not gonna be their counselor, like they're gonna terminate, you want them to go off and do great things, but you want them to be able to self-advocate and self-monitor and be able to communicate what they like and what they don't like with regards to medication.
And beyond like, I just don't like this.
Yes.
So teaching them how to say, I feel like this is I'm noticing this with my sleep. I'm noticing this with my appetite. How to advocate for themselves
Right,
that way
and not be
instead of
like, oh,
doesn't
just
work.
go ahead and stop it, be like, send them over to me, let me
Make
fix it,
lists.
let me see if I can change something around, add something in there, fix it, because if it's working partially, we don't wanna give up on that.
And thinking about the last time you went and saw your doctor, when you sit in your doctor's office and they say, how are you doing? You're like, oh, I'm good. And so it's a matter of teaching them how to talk to their doctors about symptoms and what's going on.
Well, we always remember until we're in, like, I need to tell my doctors, we make this
Yes.
like mental list, right? And so session can be a really great place to practice those conversations,
Make a
rehearse
physical
them.
list.
Yeah, right.
And then make a
Physical
list, right?
So primary care, anything they need done by primary care, I have to make a physical list, 'cause it's so hard to get a primary care appointment at the VA, it takes like 6 months. So we make a physical list of every
Put it on your phone,
Yes.
record
Yeah, if I
yourself
can't
on your
refer
phone.
myself, I write it all down for it and I have them bring it to their next appointment.
So I think knowing your scope of practice, our scopes of practice is important. Making sure that we're practicing within our scope of practice and that we're not going outside of that. As therapists, you guys are gonna end up with tons of experience, especially as you go along. And you may have some ideas about meds in your head, like, I've been doing this for 10 years and this particular medicine in my experience has worked really well for my patients who have a lot of anxiety. And you may notice that the patient's never been on that before. So I don't mind a phone call from a therapist saying like, hey, just, want to throw something out there, and we kind of talk about that before we present it to the patient. That's still staying within your scope of practice. You're not making recommendations to the patient, but you're collaborating with their provider, somebody who can do that piece of it, and we're talking about it. So I think it's just making sure, and again, that goes back to collaboration, feeling comfortable with reaching out to people of the other disciplines and being able to have those
We
conversations.
should, that's what we do in reverse. It's
Yeah.
like, I think CBTA might be appropriate for you, but let me talk with your counselor and
Mhm.
see what would really be appropriate for you the most to target these symptoms. Because I don't know which therapy is the best for you, but I do know that you do need therapy.
Mhm.
Yeah, I'm not gonna go ahead and just be like CBTA.
Yeah, excellent, thank you. Yes?
So I was just curious because I know that you mentioned like the SSRIs taking like 12 weeks. How do you motivate like patients, especially when there are things like values, Xanax, and Atamins out there that they know are going to work right away? How do you motivate them to take like an
So
SSRI for 12 weeks?
The risk
versus-
of developing dementia associated with those usually is the immediate turn on to the benzos, the addiction
Terrifying
potential,
somebody is a pretty
and the
good.
dementia
Sorry.
they become very willing to wait for those medications to kick in once I describe the data, and I can give them copies of that data and go into it as much as they want. I have a whole stack of patient handouts on benzos and all the research that's been done regarding use of benzos and formation of early onset dementia.
So so you would say more like training on medication to do best, most effectively to motivate them to take like the SSRIs?
Yeah, so we have we have things like hydroxyzine, which is Atarax and Vistrol, that's the brand names. So we do have non-narcotic, immediate relief and anti-anxiety medications. So when I'm starting an SSRI, I usually offer, hey, do you want an as-needed ARN medication for your anxiety? And if I do, it's gonna be a non-narcotic, one that's gonna work immediately. But it's not gonna be a benzo.
Yeah. And I think, from a therapy standpoint, I know one of the things that I kind of always kind of tackle it from is depression didn't set in overnight, and we can't always fix it overnight, unfortunately, and that's just kind of the medications that we work with. They take time, and so, like they said, sometimes we have to throw in a little PRN in between to bridge that gap while we're waiting for the medication to get on board 100%. And so for me, sometimes, again, depending on the situation, and I would need a lot more with her, because in my original case scenario, she was having full-blown panic attacks. That might be somebody that I might offer even a small, tiny dose of a benzo to for a very short period of time. So then it's also making sure that they understand this is short-term therapy. You are not going to be on this for more than 4 weeks. This is just to allow enough time for your SSRI or your SNRI to jump on board, because it's going to take about 4 to 6 to 8 weeks for that to come on completely. But I do want you to have immediate relief, because I'm hearing you, I'm hearing your concerns, and we need to start working on getting back to whatever that baseline was. But again, I think it's just helping them to understand that these symptoms, these things, they didn't just emerge from one night to the next, from one day to the next. This was a process that happened, and it's going to be a process to get it reversed and kind of get back to where we need to be. So we have to have time, we have the commitment, and making sure that they know that they have support. You have a support system behind you. You have me, you have your therapist, you have your case manager. You have lots of people in your corner who want to help you get to where you need to be, so you're not doing this all on your own. Let's do it together, kind of thing.
And they've been struggling with this for a while, usually before they even seek help. So it's not, waiting another 4 to 12 weeks is honestly not that long compared to usually how long they've been struggling with it.
Yeah.
'Cause usually it's like they've been struggling for years with anxiety. The other thing is that for depression, some new research has showed that antidepressants start to work even within the first week or two. So you do still see some benefit right off the bat in some cases.
So a lot of normalizing these symptoms and these challenges that they're having, so that way they are understanding their bodies a little bit better.
And just being realistic about the expectations of medications. It's not a cure. I always go over, this may help you, this may make it worse, this may cause these side effects, and what to expect in the time frame of when it's gonna work. Because, some people think that it's gonna be a magic cure, like, hey, I don't feel motivated all of a sudden. I took it one day and I didn't feel motivated and I stopped. So that means they obviously weren't listening to my whole explanation. They just zoned out for a bit. So, we always provide paperwork and things like that to go on with it, but it doesn't always work. And so as counselors, it really helps if you just really hammer that adherence to the medications and letting us know if there's side effects.
I was gonna just say thank you so much, because for those of us who work in inpatient substance abuse treatment programs, we get the patients who have been prescribed Xanax for years and
right.
years. And you have a professional who comes in and is surprised because they didn't know there was another way other than taking this for so many years, and they're so scared to detox off of it. And when they start to feel better and they've been off of Xanax for a few weeks and they're having alternative medications that they never thought would work, and they're able to go back to work, within a few weeks and, get back to their normal life without that. So I just want to say thank you for putting that out there, because a lot of times people think that that's all they can use. There's not other alternatives.
Yeah, so the benzo is kind of the quick Band-Aid that they'll just slap right on and send you out the door. So that's kind of the way to do it without really caring about the patient. And unfortunately, that's what a lot of people do. And so we end up with a lot of veterans who come to us on these benzos, so we have to take them off. And once you come off the benzo, a lot of people tell me that they experience this clarity especially after a full year of being off of it, just this new mental clarity. Like they can see clear, they can hear clear, they're just a part of life more. It's such a difference.
Yeah.
So, I'm in an integrated setting, and I've seen this work really well, right, when I talk there with the psychiatrist.
Sorry, I
and
can't hear you.
Sorry, I'm at Bayview, so I get to
Okay.
talk to the psychiatrist, I get to talk to the doctor, we're all together. But recently we had a client who, they told us their psychiatrist had prescribed them lithium for first episode depression with right off the bat, just give them lithium. And we were able to kind of catch it and talk about it. But what about a private practitioner? If I'm a private counselor and my client comes in and says, yeah, I just got prescribed lithium and I've only been depressed for 1 month or whatever. What are my options as far as interacting with the psychiatrist then?
So that was it new onset depression with no other diagnoses?
Yeah, she was,
Just
it was
major
a young
depression that day.
client, she was very newly depressed, kind of very suddenly within the last couple of months. It was-
No access to nothing.
No, it was really shocking, and I was surprised. Her parents actually brought it up to me, and I went to the psychiatrist and I said, hey, did you know that her psychiatrist prescribed this? That seems really extreme.
So the only thing, I would never do that. The only thing I could think of is that the prescriber thought the depression was severe enough to go with the gold standard augmentation agent, which is lithium, in addition to an antidepressant, which can actually make the antidepressant work faster. So that is the gold standard, but I personally would never start that off. I would start with an antidepressant that works. Lithium can cause so many side effects, requires so much monitoring. That's
So I
for
think-
later.
I think
My
that,
question is how do you,
yeah.
how do you bring that up to a psychiatrist and be like,
Yeah,
whoa.
so that's when you have to pick up the phone and you have to call that provider. So it's making sure that you have all your consents on file to be able to collaborate with that psychiatrist or whoever it is that's doing it. And that's when after your patient leaves, you pick up the phone and you call and you see if you can have a conversation over the phone. Because it may be that, again, like I said, that patient oftentimes will tell us different things than they tell you all. So it could be like you call me and you tell me what's going on. I'm like, okay, well, that's not what I got from the patient when I did the assessment. This is what was told to me. And then it may be, so that was the basis behind. But now that you brought this up to me, we need to work then and figure out what really is going on here. But that's what I mean when I talk about collaboration, and that we need to do a better job on, as a whole in doing that. We are busy. We're all busy. You guys are going to be seeing, 5, 10, 15, 20 patients a day. I see 20 patients every Monday when I'm in the hospital. I'm like, go, 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 go. There's not a lot of downtime in between. So I have to make the time. If there is something that is really standing out to me, or that I really need to make sure I communicate to the therapist for that particular patient, I have to stop and make the time to make that phone call and get it across. Okay? And so I think that that's where I say we have to do a better job as a whole in making that communication happen. And that's either picking up the phone, or finding out if there's a secure email for that provider that you can send to. You know, just kind of depends on what the situation is and how, you know, what the acuity of it is. Like, in other words, how important is it that I need to get this information across right away?
Definitely reach out. Just kind of started off like just expressing your concern. I'm just concerned. I'm just kind of wondering why there were 2 medications started at the same time. The patient is a little confused. So if you kind of bring it up that way, it's not like you're being like, hey,
Why did you
what
do
did you
this?
Because
then they'll talk to you.
Yeah, the provider may have picked up on some kind of personality disorder, like borderline personality disorder, some kind of possible bipolar disorder. They may have picked up on something.
Yeah, that could have warranted the
Or
med.
if it was suicidal depression, you know, the lithium's been proven to reduce suicide rates. So they may have picked up on something that the patient didn't tell you that caused them to really, for some reason, want to go for 2 at once.
And the
So
patient might not even
know.
know what that thing was that
Yeah.
sparked that thought for the provider. They could just be saying, you know, whatever about their physical health, and the doctor's thinking, oh, this.
So again, it's good for you to let us know, because that
We
means
could
that
have a
there's,
wackadoodle psychiatrist.
we need to
So-
educate that patient more. We need to go back and do some extra with them. So either way, you're still raising a flag for us. Yeah, for us to know, because that way we know, okay, I need to have more conversation about why I chose this med for this particular patient. They didn't have a full understanding of it.
And I also think it's super important to teach your client how to self-monitor, self-advocate. Ultimately, whether your patients, your clients want to take medication, that's up to them. That's their decision, and they
You
have
just
to find
recommend it.
ownership
That's all.
in that decision, because they're the experts when it comes to them and their body. And so really teaching clients how to self-advocate and call their doctor and ask questions, that's the most important piece to me.
And also you highlight a really good point that when you are in private practice, you're sort of on an island, where, you know, these folks may have other providers in their life, but you are on an island, and that doesn't mean that you still don't have that professional responsibility on your license to be follow-upping and monitoring about these things. And so, you know, there are private practitioners out there who on intake appointments will ask people to bring their current medications with them to verify that there isn't a mistake. Like, I believed I was taking this, but it's a, you know, I believed I was taking, you know, lithium, but I'm actually taking Lexapro. They're L words, I don't know, right? So bringing those with them to verify on those initial appointments is something that I've seen people do. And then also in those initial appointments, if someone does have a primary care doctor, if they that they see consistently, if they have a psychiatrist that they see consistently, making sure that those consent forms, those consents to communicate, are taken care of at that first session, so that even though we are on an island, we can build a small bridge for ourselves to other providers in need, and be able to think about it on the front end, rather than when someone comes in and this may be a panic moment for them, or they're experiencing some sort of side effects or something, to have them filling out that paperwork then, so that I can pick up the phone and make a call, sort of being preemptive. So the thought process of how a private practitioner collaborates is definitely different, and there's just as much front loaded on it as there is in even a fully integrated setting. It just may look a little bit different.
Definitely. And another way you could help this out tremendously is just reminding patients to bring in your medications with you, even if it's to your appointment, just so you can sort out what it is they're taking. Because oftentimes they get confused. The names on these things are just a whole jumble of these Z's, Y's, and X's. It's very confusing for patients, especially if they're elderly. It's very difficult for them to keep track of their medications because they're on so many more than younger people. So having them, yeah.
Even if they're our older generation, have them download their pharmacy app, because it'll pull up the list. Even if they never use it because they're elderly, they prefer to go pick up their prescriptions, the app will still have the list of all the stuff they're prescribed and the dosages and everything.
There's so many apps they can use. If
Right.
they can use the cell phone, absolutely keep the app.
Have the
them
case
take
manager do it.
pictures
Have the
of
case
their
manager.
medication models. Don't forget it. Like,
Excellent.
because like half of my appointments are always spent being like, Oh, I take the white brown pill in the morning.
That one. No, that one. Okay. We have time for one more.
All right, so I'm sorry, I just wanted to sort of backtrack. You were using some words that I did not quite parse in my head. So you said that frequently lithium was prescribed to do something I didn't, in.
Oh, an augmentation agent.
Yes,
So-
I got augmentation agency, but I was wondering, was it suicidal ideation?
So yeah, so in bipolar patients, if they're suicidal, you want to kind of go with the gold standard, which is lithium.
Okay, so
It's
that's
proven
the
to-
word that I didn't hear was it suicidal, was it migraine, was it, I didn't.
Oh, okay, yeah, it was suicidal. Yeah.
Okay, thank you. I was like, I wasn't parsing that word.
Anybody else? One more question, comment? Okay. Thank you all very much for joining us. Very, very